More than 17,000 Americans experience every day what physicians classify as a transient ischemic attack. Not a mild headache, not ordinary tiredness, a direct biological signal that a full stroke is hours away. And here is what nobody is telling you. In the overwhelming majority of those cases, the person dismissed every warning because no one ever taught them what to look for. That dismissal cost them everything. The stroke did not come without announcement. The announcement simply went unread. If you are watching this channel for the first time, subscribe right now. It takes 5 seconds. We are working toward 200,000 subscribers, and every person who subscribes makes it more likely that the next person who needs this information actually finds it. The healthcare system generates revenue from visits, procedures, and prescriptions, not from patients who solve their problems at home with correct information. What I'm about to tell you, no one in a clinic waiting room is ever going to say. It is late afternoon, maybe 4:30, maybe 5 in the evening. You have been reasonably fine all day. Not perfect, but fine enough that you did not think twice about it. You are standing at your kitchen counter, and something feels slightly wrong. Not dramatically wrong, not wrong enough to sit down or call anyone, just off in a way you cannot quite name. There is a heaviness on one side of your face, a subtle drooping sensation near your mouth that you notice only when you take a sip of water and the glass feels unfamiliar against your lips. The words your spouse said from the other room sounded muffled, as if they came through a thick wall, even though they were only 10 feet away. You blink. You turn your head. You decide you have been staring at a screen too long, or that you did not drink enough water today. 20 minutes later, the heaviness is gone. So you make dinner. You sit in your usual chair. You watch whatever you always watch in the evening. You go to bed around your normal time. And somewhere in the hours before morning, your brain shuts down. That is the story I hear more than almost any other story in over 2 decades of practice. Not from medical records, from patients who survived and came to sit in my office with a particular kind of grief that has no clean name. The grief of a person who knows they had the window, who had every sign laid out in front of them, and who thought it had passed. I have seen this in the eyes of hundreds of patients, and almost every one of them says the same thing. I thought it had gone away. I thought that meant I was fine. Let me be direct with you. The idea that stroke strikes without warning is a lie. It is a dangerous and medically inaccurate illusion, and it needs to be shattered right now. Most people carry a picture of stroke as a sudden catastrophe, a lightning bolt from a clear sky that strikes a perfectly healthy person with no warning and no lead time. That picture is what keeps people from recognizing the signals that arrive the day before. They are not watching for anything. They have been told there is nothing to watch for. So when a symptom visits for 90 seconds and politely disappears, they interpret that disappearance as good news. They interpret it as the problem resolving itself. They were watching for a storm while the pressure valve had been leaking for months. Think of a water distribution pipe with a section that has been narrowing slowly for years due to mineral buildup on the inner wall. Under normal operating pressure, enough water still squeezes through that narrowed section to serve the household. But one evening, the main pressure drops slightly. The flow through that narrowed section slows to almost nothing. For a minute, barely any water comes out of the tap. Then pressure normalizes and the flow returns. You call the plumber or you do not. If you do not, the next time pressure drops, the section closes completely. Your body works exactly the same way. The transient symptom was not the problem solving itself. It was the first complete partial failure of a system that has been degrading silently for a very long time. Before we go further, I need to say something as a physician with over 20 years of clinical experience. There are symptoms that should send you straight to a doctor, not to a video. If one side of your face is drooping right now and you cannot control it, stop watching and call emergency services. If one arm will not lift when you tell it to, that is a stroke in progress, and every minute you wait reduces the amount of brain tissue that can be saved. If your speech has become completely unintelligible in the past 30 minutes, you do not finish this video. You call for help immediately. And if you have developed a sudden headache unlike anything you have experienced before, what patients consistently describe as the worst headache of my life, that can signal a hemorrhagic stroke, which is a bleeding event inside the brain, and it is an emergency without exception. If none of those apply to you, you can breathe. You are going to be fine. But the quality of that life is worth protecting, and that protection begins with what I am about to explain. Here is what is happening in your body right now, and what has been happening in most cases for years before any symptom ever appeared. Every artery in your body is lined on its inner surface by a structure called the endothelium, which is a microscopically thin sheet of living cells that functions as far more than a simple barrier. The endothelium is a metabolically active organ. It produces compounds that regulate clotting, control arterial diameter, and communicate with circulating immune cells. When the endothelium is healthy and intact, blood moves through your arteries without adhesion, without clotting activation, without plaque formation. The surface is biologically non-stick, and here is what starts to change it. Chronically elevated blood glucose, even mildly elevated, even in the range physicians call pre-diabetic rather than diabetic, initiates a process called non-enzymatic glycation. This is a chemical reaction in which sugar molecules bond to proteins in the vessel wall without enzymatic assistance, producing compounds called advanced glycation end products. Those compounds stiffen arterial tissue. They impair the endothelium's ability to dilate when blood flow demand increases. And they chemically alter the surface of the vessel wall in a way that promotes the adhesion of low-density lipoprotein, which is the form of cholesterol that deposits inside arterial walls rather than flowing freely through them. I want to be precise about this. Cholesterol does not accumulate inside healthy arterial walls simply because circulating levels are elevated. It accumulates inside walls whose endothelial surface has been compromised, scratched, made rough by inflammation or glycation damage. An intact endothelium resists LDL deposition even at above-average cholesterol levels. A damaged endothelium accumulates it rapidly, regardless of what your last cholesterol panel showed. That is why so many people with normal cholesterol numbers still have significant arterial plaque. The wall was the problem, not the blood. Over months and years, that accumulation builds what pathologists call an atherosclerotic plaque, which is a dense, layered deposit of lipids, immune cells, fibrous connective tissue, and calcium sitting inside the arterial wall itself, not on its surface, but embedded within it. That plaque does not immediately obstruct the artery completely. It narrows it. It changes the mechanical properties of that segment. It makes the wall stiffer and less capable of the normal expansion and contraction that healthy arteries perform with every heartbeat. But what most doctors never check is this: the plaque's structure matters as much as its size. Research drawing on vascular data affiliated with Columbia University Medical Center has documented that transient ischemic attacks are most commonly associated not with plaques that are simply large, but specifically with plaques characterized by a thin fibrous cap, which is a fragile outer layer of tissue covering the lipid-rich, inflammatory interior of the deposit. A plaque with a thick, stable fibrous cap can sit in an artery for years and cause only gradual narrowing. A plaque with a thin, unstable cap can rupture at any moment, exposing its interior to circulating blood. When that exposure happens, the blood clotting cascade activates instantly. Platelets adhere to the rupture site. A clot begins forming on the surface of the plaque, and pieces of that clot can break free. That fragment is called a cerebral embolus. It travels upstream through the arterial system. And when it reaches a cerebral artery, which is an artery inside the brain itself, in a vessel too narrow for it to pass, blood flow to everything downstream of that blockage stops. The neurons in that territory begin to die within 4 to 6 minutes. That is a stroke. But the day before that happens, the plaque destabilizes. A smaller fragment breaks loose and temporarily obstructs a minor arterial branch. Blood flow drops, but does not stop completely. The tissue fed by that branch is deprived for seconds or minutes. Then the fragment dissolves or shifts, flow resumes, and the tissue partially or fully recovers. The symptom vanishes, and the person watching television that evening feels fortunate. They were not fortunate. They were warned. Data reviewed in a landmark study published in The Lancet, tracking over 10,000 patients across multiple countries, showed that approximately 10 to 15% of individuals who experience a transient ischemic attack go on to have a full stroke within 72 hours. The risk is concentrated overwhelmingly in the first 24 hours after that warning episode. The period you are most likely to dismiss as the window that passed without consequence is the most dangerous period you will face. And right then, the picture clicked into place for me the first time I read that data early in my career. The system was not failing without warning. It was announcing its failure in the clearest language it had, and almost no one was listening. But that is only half of what is happening. The second part is what most doctors never check. The heart's role in producing stroke is dramatically underestimated in everything patients are told about their own risk. A condition called atrial fibrillation, in which the upper chambers of the heart, called the atria, stop contracting in an organized, coordinated rhythm, and instead quiver chaotically at rates as high as 300 to 400 electrical impulses per minute, creates conditions in which blood pools inside the atrial cavity rather than moving efficiently into the ventricles below. In that slow, churning, pooled blood, clots form with exceptional ease. Those clots are then ejected into the arterial circulation during normal heartbeats and travel directly toward the brain through the carotid and vertebral arteries. What makes this particularly dangerous for the person who has not yet been diagnosed is this. A significant proportion of atrial fibrillation is intermittent. It comes and goes. Between episodes, the heart rhythm is completely normal. A standard electrocardiogram taken in a clinic captures 10 to 20 seconds of heart rhythm. An episode of atrial fibrillation that occurs once a day for 3 minutes will be completely invisible on that recording. The patient receives a normal ECG result and believes their heart has been cleared. It has not been checked. It has been photographed for one frame of a very long film. I want to tell you about one of my patients. I will call her Dorota. 58 years old, a retired school teacher who spent 30 years managing a classroom of children who could not sit still. Not someone who complains easily. Not someone who comes to see a doctor until she is past the point of managing on her own. And when she finally came in, she was well past that point. She described what she called a weird pressure behind her left eye. Not a headache exactly, more like a hand pressing on the eye from inside. It had come and gone 4 times in the preceding 10 days, each episode lasting less than 2 minutes. She had attributed it to eye strain from reading. She had also noticed, on the morning before her appointment, that her right hand had felt unfamiliar while she was pouring coffee. Not numb, she told me carefully, just not mine for about a minute. I asked her one question. Which side do you sleep on consistently? She looked at me the way patients look when a question seems too basic to be relevant. She said she had slept on her right side every night for as long as she could remember. I sent her immediately for a carotid duplex ultrasound, which is an imaging study that simultaneously evaluates the anatomical structure of the carotid artery in the neck and the velocity and turbulence of blood flowing through it. What the vascular radiologist found was a 68% stenosis in her right internal carotid artery, meaning the vessel had been narrowed by 68% of its original diameter by a heterogeneous plaque with a thin fibrous cap. She was days away from a massive hemispheric stroke. The internal carotid artery is the primary supply line for the cerebral hemisphere that, in most people, controls language production, voluntary movement of the opposite arm and leg, and the higher cognitive processes that make a person who they are. A 68% stenosis in that vessel is not a finding that is monitored. It is a finding that is acted upon. Dorota's symptoms had not been random. They had been a precise anatomical diagram of exactly where her blood flow was compromised. Her brain had been speaking to her in the only language it had, and she had almost waited too long to have anyone translate it. Most people have a Dorota somewhere in their history, a symptom they filed away, an episode they explained with a comfortable alternative. They just do not know yet which episode that was. Now, here is what I need you to understand about what you are doing every day that is accelerating the exact mechanism I just described. The first is dehydration. And this one surprises nearly every patient I say it to. You are almost certainly more dehydrated than you believe, because after the age of 45, the sensitivity of the thirst mechanism declines measurably. Research from the Institute of Medicine has documented that older adults consistently reach clinically significant dehydration before registering any sensation of thirst. Dehydration raises hematocrit, which is the proportion of the blood volume that consists of red blood cells rather than plasma, and increases blood viscosity, which is how thick and resistant to flow the blood becomes. Thicker blood moves more slowly through a narrowed arterial segment. Slower blood clots with greater ease. In an artery that is already compromised by plaque, dehydration removes the last margin of safety between adequate perfusion and a complete blockage event. Write this down somewhere you will see it. The second is chronic high sodium intake from processed and packaged foods. Not primarily because sodium raises blood pressure, though it does that as well, but because excess dietary sodium directly suppresses the production of nitric oxide in the endothelium. Nitric oxide is a signaling molecule that causes the smooth muscle surrounding an artery to relax, widening the vessel diameter and improving blood flow through narrowed segments. The enzyme responsible for producing it, called endothelial nitric oxide synthase, is measurably downregulated by chronic sodium excess. When nitric oxide production drops, the artery loses its ability to dilate in response to increased demand. In a vessel already narrowed by plaque, losing that compensatory dilation capacity means losing your only remaining buffer against a complete blockage. The third is something almost no physician mentions to patients about sleep. Consistent, unvarying sleep position, specifically sleeping on the same side every night for years, produces prolonged nightly compression of the carotid artery on that side against the surrounding cervical structures of the neck. In a young, elastic artery, this causes no meaningful harm. In an artery with established plaque and reduced wall compliance, repeated mechanical compression at the same site each night can promote localized clot formation at the plaque surface. Cases documented in vascular neurology literature have traced TIA events to nighttime hours in patients whose symptomatic artery corresponded directly to their habitual sleep side. It is a small variable. In a system already operating without margin, small variables are the ones that tip the outcome. Now, I want to give you something concrete. I call this the 24-hour SHIELD protocol. It is not a medical treatment, and it does not replace the evaluation I am about to describe. It is a set of physiologically grounded protective behaviors you can begin today. Part 1. Morning hydration before everything else. Within the first 15 minutes of waking, before coffee, before food, before your phone, drink 16 fluid ounces of plain water. Your blood is at its most viscous state in the early morning hours because you have gone 7 to 9 hours without fluid intake while simultaneously experiencing a natural low point in blood pressure. This combination, thickened blood and reduced perfusion pressure, is the physiological environment in which overnight and early morning strokes occur at their highest rate. Rehydrating immediately upon waking thims the blood, raises intravascular volume, and helps restore adequate pressure before you begin any physical movement. Part 2. The morning blood pressure check. If you are over 50, you need a home blood pressure monitor. They cost between $20 and $30, and they are one of the most important diagnostic tools you own. Take your reading each morning before coffee, seated with your arms supported at heart level. You are looking specifically for 2 thresholds: a systolic reading, which is the top number, at or above 180, or a diastolic reading, the bottom number, at or above 110. Either of those alone warrants an immediate call to your physician. Both together, with any neurological symptom, any facial asymmetry, any arm weakness, warrants a call to emergency services without delay. Ask your doctor in advance what their specific threshold recommendation is for your situation so you know exactly when to act. Part 3. The FAST assessment. 30 seconds every morning. FAST stands for face, arms, speech, and time, and it is the clinical screening protocol used by emergency medical personnel in the field. F. Look in a mirror and smile. Check whether both sides of your face move symmetrically. A. Raise both arms to shoulder height and hold them there for 10 seconds. A stroke in progress will cause one arm to drift downward involuntarily. S. Say a full sentence aloud. Assess whether the words came out clearly and in the order you intended. T. If any of those 3 assessments shows a problem, time is your critical resource. Every minute of delayed treatment in an acute ischemic stroke is associated with the loss of approximately 1.9 million neurons. Act immediately. This assessment takes 30 seconds, and it should be as automatic as checking the weather. Part 4. Dietary omega-3 fatty acids. Research from Harvard School of Public Health has documented that dietary omega-3 fatty acids, specifically the EPA and DHA forms found in fatty fish such as salmon, mackerel, and sardines, measurably reduce platelet aggregation, which is the tendency of platelets to clump together and initiate clot formation, and reduce the inflammatory signaling responsible for fibrous cap destabilization in atherosclerotic plaques. 2 to 3 servings per week is the dietary threshold associated with meaningful vascular benefit in the published research. This is not a supplement recommendation. This is food functioning as direct vascular medicine. Part 5. one phone call. If you have experienced any brief neurological episode in the past 6 months, even once, even for 60 seconds, contact your physician's office and ask by name for 3 specific evaluations. Carotid duplex ultrasound, which images the carotid arteries for plaque, stenosis, and blood flow turbulence. HbA1c, which measures glycated hemoglobin and reflects your average blood glucose over the prior 3 months, catching pre-diabetic vessel damage that a single fasting glucose test will miss entirely. And Holter monitoring, which is a 24-hour continuous heart rhythm recording capable of detecting intermittent atrial fibrillation that a standard clinic ECG will never catch. Dorota did exactly that. 1 week after her procedure, she came back and said quietly, almost not believing herself, "I feel like myself again for the first time in longer than I can remember." After 1 more month, she was back in her garden every morning before anyone else in her house was awake. How old are you right now? Write it in the comments below. I want to know which age group makes up the majority of people watching this channel, because it will directly determine what I focus on covering next. Here is exactly what to do after watching this. Step 1. Write down every brief neurological episode you have experienced in the past 6 months, in plain language, and bring that list to your next appointment. Do not rely on memory in a clinical setting. Step 2. Ask your physician specifically for carotid duplex ultrasound, HbA1c, and Holter monitoring by name. Do not wait to be offered these tests. Request them. Step 3. Begin morning hydration tomorrow, 16 ounces of water before anything else. Step 4. Check your sleep position tonight and consider alternating sides from this week forward. Step 5. If you do not own a home blood pressure monitor, order one this week. It is a $30 investment in the most important data point you can track. Your doctor is not going to walk you through this at your next appointment. There is no revenue in it, and there is no time in a 12-minute office visit to explain the mechanics of endothelial glycation, fibrous cap instability, and intermittent atrial fibrillation working together in the same vascular system. I am Dr. Candace Miller, and I have spent over 20 years watching what happens when people mistake a vanishing symptom for a resolved one. A warning that lasts 60 seconds and disappears is not a problem that fixed itself. It is a system telling you precisely and urgently that it is approaching failure. Most of the time, the outcome was entirely preventable. The protocol I just described requires no prescription, no procedure, and no money beyond a basic blood pressure monitor and 2 servings of fish per week. It requires only the understanding of how your body actually works and the discipline to act on that understanding before the window closes. Subscribe to Dr. Candace, hit the like button, and help us reach 200,000 subscribers. Every person who subscribes makes it more likely that the next person who needs this information actually finds it. This video is for educational purposes only and does not constitute medical advice. Always consult a qualified healthcare provider before making any changes to your health routine.